Good afternoon, and I'm Chris Fant. I want to welcome you to our asthma grand rounds, the first of the year and the first of the decade, and I think it's probably the beginning of our fourth decade of asthma grand rounds presentations. And before we begin, I just want to mention for those who are joining us by live webcasting, you will have an opportunity to submit a question. The best way to do it is to text it to the phone numbers shown on the slide, 617-513-6043. And then if you'd like a CME credit, for those of you who want it here in the auditorium, just sign up on the entrance there. But for those watching online, if you'd email to cfant@partners.org your name, your MD degree, and email address, I'll make sure that the information gets to Harvard and that you get your CME credit. And on occasion, there are technical problems with the live webcasting. If you have any problem, I just wanted to know that wanted you to know that there's online, real-time resource available to you. So if you're having a problem with the webcast today, just send an email to bwhwebcasttroubleshooting@partners.org, and we'll try and get it fixed right away. All righty, so it's a great pleasure to introduce Dr. Bernard Kinane, known to most of you already here in the audience today. There's three things you should know about Dr. Kinane. One is that he's chief of the Pulmonary unit at the MassGeneral Hospital for Children. Two is that he's won just about every teaching award that is given at Harvard Medical School and Mass General Hospital. And three is that he's an honorary fellow of the Royal College of Physicians in England and in Ireland. And we're delighted to have you here, Bernard, to talk to us about exercise and asthma. Dr. Kinane.
Thank you. Thanks for having me. Oops, I'm even getting texted about the webcast. Ooh, we do have the Olympic Committee watching us, so I better be good. So that probably means I cannot. I'm going to be fact-checked for this. It's an honor to be here, and it's also most of the work was done here in the 70s by Eugene McFadden, and I feel a little intimidated walking over here and giving this talk, and I'm going to quote him quite liberally. I do have conflict of interest, as most of you know. I do genetics and genetic pulmonary research, so I have what's called corrector therapies for Sarepta Pharmaceuticals for muscular dystrophy and gene therapy, and I actually sit on the DSMBs of Sanofi Genzyme for gene therapy and corrector drugs for CF, for lung disease. Now, I'm going to show you a lot of old slides, and I'm going to show you some real-world data. And I want to show you this. I want to open up with this and define the extent of the problem. Most people have no idea of the extent of problem with it in athletes. And now this is a study, it's from 2000. This study was performed on actual people that were going to the Olympic Games in the US trials. And they were measuring lung function before and after the event. So they were going to get the real data and what the potential, and it was really well done. Like they went out to the field, got the atmospheric pressure on those vitelegraphs working just fine and measured it. And it's amazing what they did. And so this is a great study. And I just want to point out a few things. The cross-country skiers are at -18, which doesn't seem so charming. I did not think hockey rinks were 10 degrees to 13 degrees centigrade. That seems a little bit hot for a hockey rink for me. And then look at the ice skaters. I want to point out the speed skaters. They're not at atmospheric pressure, which will affect what we're going to see in the results. Now look, I want you to put a part of the concept of exercise-induced bronchospasm. Look at it. It is 50% among cross-country skiers. 50%. Figure skaters are not doing much better. Okay, the hockey guys seem to be doing the shifts, and they're only at 15%. Now, what's really amazing is the speed skaters, 43%. Pretty good data for it now. Now this is the raw data from the paper. And it's a little scratchy, but when they measured the FEV1 on every patient and combined the whole lot, right, the FEV1 went down in all comers 25% 5 minutes after the event, which is amazing. Some of them went down 60%, which is really, really amazing. So, you know, you begin to wonder, how could you do so well if your FEV1's down 60%? It's really amazing to see the numbers. And then just FEV1 forced vital capacity. Look at the 20% drops that we're seeing averaged out among those who didn't drop and those who did. So a big problem here. Now, I'm going to quote Wheeler here on the pathogenesis, and I just want to point out a few definitions, and we all get caught in our own world. But, you know, looking back, this makes a lot of sense to us. There's a thing called exercise-induced asthma. That assumes that you have asthma beforehand. Good criteria for asthma before. Exercise-induced bronchospasm means that you didn't have asthma beforehand and only you get it with severe exercise. Now, there's a little bit of exceptions to all of this, but now I have to quote Eugene McFadden. I'm going to quote him liberally here. Now, he describes, this is actually, it was published in 1994, but this is a patient from actually in the 70s. And you can see, what we can see is you see what's called the exercise. This is the way they did it, and I'll tell you the problems with the mechanism. So they exercised them, and then the PFVs went down. The FEV went down quite significantly. Pre-treated them. It went up, right? The baseline went up, but it still dipped. It's interesting. Interesting sort of concept. Now, this is not intended to show what it's supposed to show here, all right? This is a drug trial. And the purpose of this drug trial is to show that the discus and the inhaler are roughly the same. But I want you to show you what the actual data and the controls look like. Okay. Now, if you look here, you see these are the athletes. Look at the dip in FEV1s. Pretty dramatic drips in the FEV1s. And these are, I just want to put across, they're more significant than you think. It depends how you measure them. See the dips. And then this is pre-treated with salmeterol. They wanted you to take away the story that both of these were the same, but we'll talk about that later. Now, when you break it down into more detail, it gets even a little more interesting. If you put the asthmatics in one group and the non-asthmatics in the other group, you see COPD all over again. And you see what's called, look, if you look at the exercise-induced asthmatics, you see, you know, symptoms decrease with inhaled corticosteroids, positive methacholine challenge, eosinophilic inflammation. Good evidence for all these, and I'll go into it in detail. If it's non-asthmatic, it doesn't really have a methacholine challenge, which is interesting. And it's often neutrophilic. And we've heard that before. So it's a different sort of story, a different type of story. Now, going back to Eugene, some of his original work. Now, this was noticed from very, very early on. If you are running in the wintertime, your FEV, you're an asthmatic, fell. This was the strategy. If you're running in the fall, less of a fall. Summer, and then when they give you one. This is what set up the whole study as we know it. And so this set up a lot of concepts that set the whole thing up. Now, I'm going to talk about what you call, it is very, very important to look at all these. You may not be used to it, but we're all used to looking at FEV1s. It is important to think about minute ventilation or minute expiration here, just to remember that, because there's going to be big, huge differences. So for example, if most people's minute ventilation, they don't work very hard, right? Like if a brisk walk will not get your minute ventilation up very much. So you might not see much of a dip. You really do have to get what you call the minute ventilation way up to see the dips. Okay. Now, it doesn't matter how you get the minute ventilation up, you will see it, exercise or otherwise. Now, this is the original paper from where this comes in 1984, and it was actually done in this hospital. Now, and they were looking at heat exchange, right? The physics of this, and I'm pretty good at mathematics, the physics of this are even beyond me. So what you call, read the method section of this, and you say, whoa, wrong degree. So to give Eugene some, they were looking at heat exchange, but I want to point out a few things here from which the information comes. So change in FEV1. Now look, and they're breathing various forms of air. Now the black dots, see the black dots up here? Sub-freezing air. More of a drop, okay? Then you look at the, like if you go all the way down here, body temperature air fully saturated, nothing. So it's something to do with the saturation and the temperature. Something to do with the saturation. And that's where the theories all come from. Now there's a few caveats to this, and we'll talk about it a little bit. Now, on this side, down here, is what we call the older theory. The newer theory is over here. And the answer I want to talk to you is halfway in between, as it always is, now look, so the initial theory was that you'd take this cold air in, it has to go down farther, so it's not warmed up or humidified when it gets in your nose, and it goes deep into your lungs. Okay, and when it gets deep into your lungs, it causes vasoconstriction, and then the body rapidly vasodilates, just to heat it up. And then you lead to engorgement of the airways and edema. That's the essential theory area. Now, this theory had a couple of problems, with it. And this sort of said that asthma would really only occur after the event, when he was with the whole thing. Now, the way they did the studies was they were doing 5-minute exercise, aggressive 5 minutes, 5-10 minutes. Now, most athletes know that it comes on at 5 to 10 minutes, whether you stop or keep going. Now, there is a concept that you can run through your asthma, but when it gets really bad, the 5 minutes is important, but you're going to see it. And this is where a lot of now, we know this actually because the Olympic Committee went out and tested it on cross-country skiers. So they measured before, on the intervals, and in the end. So they could see which called the PFTs were already down mid-race. They could see that. And he came and gave us a talk with her, and it was amazing. He got his skis out and raced out after him, the right way to do it. Now, the other theory that's gained a lot of traction recently and has a lot of new evidence that supports it, effectively what they're saying here is you're taking in dry, cold air. You have to humidify it. So that means the water comes off the airway fluid and dehydrates it. So it's got a high osmolality, it's dehydrated, shrinks the cells, and then you get all your mediators released. Now, there's good evidence about all the mediators released, some conflict of evidence, but very good evidence, and hence that direction. Now, the question was the reason why this theory, this one over here puts some question on the original one about swelling induced to cold air, and this study actually switched us over to thinking about what you call the hyperosmolar dehydration theory. And effectively what this says, they did a whole series of patients like this. I actually don't agree with this study, but I'll show you. They did ones where they're breathing in 37 degrees, not completely humidified, and then they did ones who were breathing in 15 degrees dry. And the response was the same, the response was the same. However, there's 10 other papers that says the opposite. But this got people thinking about, is there something else? There are 10 that says the opposite. Now, this is a really good paper, and what this one said was, if there was dehydration of the airway, the cilia won't work. And that's what they were getting at. And this was looking at mean clearance with the cilia. And in the asthmatics, and I just want to say you see a dip with exercise. In the healthy, you don't see quite the same dip. That's what you're saying. Now, this has also problems. So say, for example, you're a totally healthy person out there and you decided to do cross-country skiing and freeze yourself to death. Doesn't that apply to you as well as the asthmatics? You know what I'm saying? It says there's something more. So it says there's something more. So I don't think the story is quite given. There's something else that we're missing here. Because you can make the argument there. It would dehydrate a non-asthmatic as well as a non-exercise bronchospasm as well as an exercise bronchospasm. Why doesn't it? That's a really interesting question. But you'll see interesting thought process. Now, then I just say what happens is really, we'll say just it's osmotic strain or freezing strain, whatever we choose to take. But it leads to the same outcome, actually. The number of eosinophils in the sputum correlate with the severity of exercise-induced bronchospasm. These eosinophils, as you know, I don't have to look at tryings. The mast cells also release. I don't have to tell you that sitting to this audience. I do not have to tell you that. There's no. But what's the evidence behind all of this? Now, here's Anderson's study in 2006, and it's worth a look, and it really does point to a similar mechanism towards asthma that you and I are used to. And you'll see why I do therapy slightly different to a few of my friends. So you see, with histamine's released, triptase is released, and which called cysteine leukotriene's released. Pretty good significant values. So clearly the inflammatory markers. Now, the only thing that I don't understand, this is a really good study from Takeda, and what Takeda proposed, he was looking at nitric oxide, and he got the opposite result. Nitric oxide goes down in these exercises. So here you have what's called, just let's go over here on A, you see the drop in FEV1, and then what's called, see, the NO goes down in these as well. Interesting. Now, this has been reproduced a number of times, so it means something. But how it fits into the standard theory, I don't know. Standard theory. And so it's just interesting. Now, and it's really interesting because everybody tries to measure NO in these people, and it actually goes down, and I wonder what it means. Now, how do you know somebody has exercise-induced bronchospasm or asthma? Now, and this is, I want to say, static measures are often not the best. That's what Eugene's saying here, and it's absolutely true. Now, if you looked at a lot of those asthmatics that were going down 50, 60%, they would look normal at baseline. These studies are worth looking at. Now, these are the tests we do. We do 6-minute walk test. All of these tests we do. And the exercise bronchial provocation and the CPAT are the ones that we're doing right now. Now, the exercise bronchoprovocation is a really interesting question to try and get at. How much exercise? What's the evidence for the right amount of exercise? Is a challenge. Okay, it really is a challenge. And I wanted to take you back. The reason why I wanted you to go back is how much exercise is enough? Now, you see, you have to be getting the minute volume way up there to see it. Now, so Eugene proposed, and to give him great credit, he was supposed to what's called a 50% max. I propose a 50% max might not be enough. You may need to get it way up to 75% max to really see it. So there's a problem with the exercise. So if it was negative, and we do it like we do it about 50% max now, it may not, if it's negative, it might not be negative. And we also do it, we do it in warm temperatures. Let me slip back. Sorry about this. So that's the problem with the exercise. Now the CPAT, most of you are used to using it for pulmonary rehab, adult cardiac rehab. But it is actually cool from a pulmonologist point of view. And it is, from an exercise person, we like doing them because it gives us great information. And you'll see what the information will show you later on. There's more information there than you want. And they're fantastic for designing training plans and all these other things that you worry about. Now, and I just want to give you what's called the criteria which is set up by Auburn and Boulez, So basically what they're seeing is a 10% drop in FEV1. Now, I want to remind you that the Olympic study I showed you was a 15% drop. And when they were using a 15% drop, they were seeing incredible numbers, So it's a significant problem among athletes. So generally they're asking a 15% drop, and then the usual methacholine mannitol challenge, 20% and 15% drops. They use these as standard. But I do want to go into CPATs for a second. And every pulmonologist cringes. If you don't do CPATs, you cringe and get under the bed right now. But it's not. There's a lot of useful information, and there's some tricks in CPATs that are very, very helpful. And I do want to give credit to a few people who are watching. I want to give credit to Pat in the lab and Christina, because they really got into getting them look right from a pulmonologist point of view, as opposed to, and there's some really information. Now the things to I just want to remind you of a few things here. So we're proposing a concept of breath stacking, because you can't breathe out. Okay, propose concepts. Now, if you propose the concept of breath stacking, that means your inspiratory capacity goes down. Just to remind you what inspiratory capacity was. Remember this thing? Remember all these inspiratory capacity, end-tidal inspiratory capacity, all right? All right. Now, you never thought I was going to be talking about inspiratory capacity when I came over here today, but that is a very, very important. Now, what it does in CPATs, let me tell you what happens. This is a normal kid who's on the bicycle in this case, okay? Breathing like this. And what happens is the breathing goes up and fills out the loop, okay? This is centered by the inspiratory capacity, okay? If the inspiratory capacity goes down, this curve is pushed up by centering. We're measuring no physiology. So when you see the curve on the treadmill going up like this, and you've got the centering right, you have what you call small airway disease leading to dynamic hyperinflation. You are watching dynamic hyperinflation going on in front of you. And it doesn't prove small airway disease, but it does prove dynamic hyperinflation for whatever reason. Okay? So we do like doing this, and it's amazing. We can have statics that look normal and poorly done exercise. Now, remember, these go to VO2 max. That's what they do. They push you to VO2 max. And remember, your VO2 max or your minute ventilation is way lower than these super athletes. Then they're pushing it. They're really pushing it. So that's the advantage of this test. You're going to get super max, and you're going to get extreme end. You're going to be pretty sure of what you're seeing. Now, I don't want to go into this too much, and this is from Eugene in 1994. I want to set up that if a kid is short of breath with severe exercise, asthma is not the only explanation. And the other thing I want to point out, if the test doesn't say, if you've got good clinical evidence that the kid has exercise-induced bronchospasm, you may not have done the test right. You really have to be very critical on what you did. Very, very critical on what you did. Now, I want to bring you back to some old-fashioned data here. And I want to point out what's allowed and what's not allowed. It's pretty important to know what's allowed. Now, and I also want to point out that we are pulmonologists and we tend to work in isolation, okay? And I want to show you how we shoot ourselves in the foot, big time. Big time. We shoot ourselves in the foot, and we don't realize we shoot ourselves in the foot. Now, and every Olympic athlete knows about it, but we don't. Now, so we all agreed that giving salmeterol, albuterol, and terbutaline works great. We'll all agree with that, okay? This is cromolyn. Works pretty good. Most of us don't remember this anymore, and certainly most of us haven't seen a doctor in so many years. Well, we wouldn't give these very much. Now, what's really interesting is the anticholinergics don't seem to work as well. There's one exception to that is swimmers. As swimmers use bronchitis, it does work well, but the rest, it does not work well. Now, when you're making your decisions, you have to, you have to know what the guidelines. Now, these is the doping regulations. These are the doping regulations at this moment in time. And I want to point out a few things that we forget about. Most of the medications that we use are allowed. Okay, terbutaline is not. Okay, terbutaline. The two LABAs that are allowed. Okay, the others are not. Okay, the others are not. And then the rest, oral fluorospheres are prohibited. Okay, hopefully you're not going in, and then omalizumab is permitted. So these things have to come into your decision making when you're dealing with these athletes who are. Now, these things also apply to collegiates as well. The same rules apply to collegiates, and even in state, same rules apply to state. If you get tested, you're going to fail. You're going to fail. So it's pretty important to get it right, because they're very. You can imagine they're incredibly upset if they win the medal and fail the dope test. That is not the way to go. Not the way to go. Now, I want to point out. Now, this one is. This is actually a pretty important slide, and it's a pretty important from Eugene McFadden. And this is some really. There's some wisdom here that's actually worth looking at. And what I want to point out is bronchodilators work at rest. They work very well at rest. When you stop and give yourself a puff. If your minute ventilation is going like crazy, okay? See the dips. Let's take our favorite drug, beta agonist. We all love our beta agonist, right? We love our beta agonist. See, when you turn up the minute ventilation, look what happens. It loses its effect. So you have this kid who's doing cross-country skiing. I'm using that as a good example because of the classical sport. Or doing track, long distance. And he's turning his minute ventilation up, right? Now remember, all the studies I showed you about beta agonists preventing this, right? They were done on short bursts of exercise, and the patient stopped. And then they measured their PFTs. The patient stopped. So these extreme athletes are having a little bit of a problem here. So you'll often find, and I'll show you what people combine. See this combination here that you don't think about very much? Don't think about much. Now, these skiers, the people that are on the national teams, they often ask you to give. I actually have, since I have an overseas medical license, I do have a license to write for Cromlin, and they fill it when they go to Canada or Europe. They fill it, the inhaler. They fill the inhaler. So it's quite common for skiers to know about these things. And they know these things better than you and me. Now, what do I do? And what do I advise my patients to do? Now, I'm going to commit some heresy here for a second. And I'm giving beta agonists 5 minutes before. Everybody who in this room says 15 to 20 minutes before. And I'll explain why. And I didn't put up a provocative picture, which I'm glad I didn't now, because since looking who's on the audience here, watching me online, so I didn't put up a provocative picture. Now look, but I also do, particularly for kids, it's very important in sports. If I put them on maintenance therapy, in those who train in environments that induce airway inflammation. And what I mean by that is soccer players, people who are running cross-country in the springtime in high, which are called pollen environments, I do. The people who are exposed to cold with training, people who are exposed to extreme exercise with training, which is a lot of them, and I put them on a combination of LABA and inhaled steroids. So I take the approach, and there's no evidence and no study really done for this. I take the approach that which call, if you're exposing yourself to these toxic environments, that which call you're inducing chronic inflammation, and you should treat it. It keeps you out of trouble. It keeps you out of trouble. Now, I want to show you a few other things that we don't take into account when we're giving advice to people. If we're involved in cold weather sports, should you wear a mask to result in some rebreathing and increase the humidity? And the answer is yes. The answer is yes. This is a good study from Denmark, which addresses this straight on in very, very competitive athletes. So if you look here in the circles here, you're seeing going down the regular asthmatic without anything. This is which is called the exercise-induced dip. That one with a face mask. This one with beta agonist pre-treatment alone. And it's a combination. So the answer is you should take the combo. The answer is you should take the combo. Now, the other thing is you should warm up. Now, the warm-up, the problem with warm-ups is what's too much and what's too little. Okay, and I don't know, I don't have the answer. Now, this is a study from Mickleborough, and he is, it's really, really well done. Mickleborough's really, really well done, and he clearly put a lot of thought process into it. And I did send an email to him to find out what does he actually advise, because what he does is he puts them on the treadmill. I've seen a few of the collegiate athletes do this on TV, actually. I've seen them do it on TV, and I've been watching them, what they do before the thing. And they're clearly doing it. And now a lot of this, the big schools that do this, believe it or not, are Stanford. Watch the Stanford athletes and see what they're doing, because they're great. And then which called Ohio and Texas A&M are the big schools that have really great programs. And it's good to watch them and see what they're doing, what's on the track side. Now, the thing I wanted to bear in mind was what he did was 8 30-second runs at max. That's 4 minutes of max running before a competitive event. Like, that might be a bit too much just from actually be able to finish the race, okay? And then he looked at, give him 40 seconds to recover between sprints, and this was peak velocity. That means you're all out from the start. You're all out from the start. Now, just to look at the data just for a little bit. Now, this is the one here in D, so going across here, this is the one without any treatment. And you get the usual dip. This is the one here with the, which called warm-up. Warm-up plus inhalers. The inhalers up here, and then the warm-up plus inhalers pushes the whole way up. So the answer to the question is really, you should warm up, but how much? And if you're exposed to cold air, you should wear the mask if you can. Not everybody can. Okay? Not everybody can. Now, I want to switch over to something that's particularly important, vocal cord dysfunction in this group. Most people, because we're pulmonologists, we actually think asthma. I'm going to propose to you, as you'll see, they're equally as common. And there's significant overlap. Now, I do want to go to Nielsen's study from 2013 in sports medicine, because they get at it. They really do get at it. And they did it really well. I'm not sure anybody could have done it. I don't want you to bear too much thought of what's up there, but I'm going to put it here. Don't want too much thought up there, and I want to call. Now, so they took some incredibly good athletes, and just looking at their numbers, they are incredibly good athletes, and so incredibly good. Now, there was 88 patients. Now, they didn't find a cause in 31, excuse me. So just say it really isn't 88 patients. Just say it, just for the argument of numbers, it's going to be about 60 patients or less, 50 patients or less. So 50, just say 50, just to make the numbers easy for us. So 50 patients are not in this list. And this probably means that they were just reaching their physiological limit, and you were built that way, and that's the way you are, okay? I'm not going to win the 100-meter sprint anytime soon. So, yeah, I wasn't built that way. So these people who were quite built for what they were performing in. Now, but if you look here, and this is called a vocal cord dysfunction. I do like EILO, exercise-induced, what was it called? Laryngeal occlusion. It's I do like the EILO. It has a sort of a nice bend to it. But if you look, 26, about half had asthma of this, if you pick the numbers right. And half had, another less than half had what's called exercise-induced vocal cord dysfunction. And then there was quite a significant overlap at both. Quite a both. Now, we do see this. And we see it, and I think what you call about roughly equal frequency is about right. I would have never said that 10 years ago, but now I would say it's about right. And not everything's asthma. Maybe Ken should give that lecture again. Not everything's asthma. But maybe that's what it is. And this is really, really well done. And it does match with what we see in practice. And these are very good athletes. Now, I do want to give to the group back home and the home institution led by Chris Hartnick. And you see a few friends of mine here, Christina and Shannon, on the study. But all this I don't want you to get into the details here, is in competitive athletes, biofeedback works really well. That's what I want to give you. Competitive biofeedback works really well. Now, this is where the next slide I want you to cringe. because I put this up to what you call drive you over the end a little bit. Now this is what you call this is what us in exercise physiology think about all the time, and and it's not that hard, to be honest. You know what you call this means your lungs take in the air, your heart pumps it around, and the muscles better take it up. That's what it means. Okay, we've spent the last 35 minutes talking about this. Now, to push it a little bit more, I just wanted to talk about exercise limitation in a healthy patient. I want to say in a healthy patient. I don't want to talk it in a, I know if you've got, hypertrophic cardiomyopathy, but hopefully we're not seeing these patients. Now look, so here in the pulmonary side, I'm putting these right up there in front. And of course, there could be your usual lung disease, but we're not going to be seeing it with any frequency. I do want to point out anemia, big time. And we'll come back to that. I want to come back to that in a second. And in conditioning, you all know it. And I'm going to say, how does beta agonists affect the heart? Not good. I'll show you. And neuromuscular, and I mean more neurovascular. I don't really want to get into this too much here, but there's a developing, when you have a lot of these kids who go run and faint, okay? And we push them all off to get into hook, arrhythmia workup. But you're left with a group that have this sort of fainting at the end of exercise. And there's evolving, I don't know what to do with it. And there's an evolving concept that there's some neurovascular thing going on there. Now, and you can actually see it. And then, interesting, conditioning, and I want to talk about conditioning. Everyone thinks conditioning on the heart, but also, which called, if you're conditioned from a muscle point of view, you've got more myoglobin. Most people seem to forget about that. The more you train, the better the myoglobin. But the more you train at altitude, which if you're in cross-country, I would encourage, if it's good to train at altitude. It increases your muscle myoglobin, and it increases your hemoglobin, and it'll answer a few of the problems. Okay, it led to the concept of blood doping as among cyclists, as you'll know. Now, I want to go to this Fick equation. I know everyone's cringing at this point. He put up the Fick equation, and what is he going to talk about the Fick equation? It's pretty simple. The amount of blood that I push around is proportional to cardiac output. And he's looking at more delivery, plus the difference between the arterial and venous. Okay? Blood's carried by hemoglobin. I just want to, which we all know. Say, for example, your hemoglobin is 12 grams. Okay? And you increase it to 13.2 grams. Everybody in this room is not limited by their lungs. They're limited by the heart. Okay? They're limited by your heart. You could possibly turn up your exercise tolerance by 10%. Now, this is particularly important in teenage girls. They get their periods, and they drop their, which called hemoglobin, down from 13.5 or 14.5 down to 12. Okay? So when you actually come with an exercise problem, we will send you to the lab, not for your eosinophil count or your IgE. We'll send you for a hemoglobin. Have you had a hemoglobin lately? Okay? And we do aggressively treat them. With iron. We really do aggressively treat them with iron. It is actually, and patients love you. Patients love you when you make them. Now, just, they're talking about 1 second differences. These can make huge differences. Now, I'm going to pour a little bit of water on our beta-2 agonists. I'm sorry about this in this audience. Most people don't know that beta-2 agonists cause dilation of the blood vessels in your skin. Okay? If you get a dilation of blood vessels in the skin, like it's quite significant. You go from 5 to 15, so you can see that's quite a lot. Okay? This is a way of measuring it. The atropine, hypertrophium, less so. Just to give you an idea. Now look, you said, well, what does that matter? It means that it does not go to the muscles. So if you have a cardiac output that's huge, and you improve their lung function, giving them a bronchodilator, you may have shifted the blood away from the muscles. And, if you shift it away 5%, well, it's a problem, because they're talking about 0.1 of a second. It's a real problem. So hence, except the good news for most of us, it takes 20 minutes. So that's the reason why I give the bronchodilators 5 minutes before. It's the reason why I give the bronchodilators 5 minutes before. Now, I thought I was a smart, cool person. I was going to figure this out. But every Olympic athlete knows this already. And then I went back and they said to me, you got to look at this video. And actually, somebody who's online here, actually sent me the video. And sent me the video. He says, you got to look at this one's video. See? So what happened was they were having the 400 meters at the Olympic Games. And I won't say which one because I might get in trouble for it. But so what happened was, you know when they pushed the blocks out of the way? Well, when they pushed the blocks out of the way, the camera stayed at them for one quirk. And guess what were on all the blocks? The inhalers. They were all taking it 5 minutes beforehand, and they were ignoring our instructions to take it 20 minutes before the sport. They were all ignoring us. Okay. Now, and then I asked somebody else, and we were talking about, and this was, and I try to be vague here because, so I told one of the swimmers, and she said, I know that, but I also know to wear an extra tight suit. And I said, well, isn't that for swimming through the water? And she says, no, but it also reduces the blood flow to the skin and diverts it to the muscle. And I would have never dawned on me. I thought it was all about dynamics. But, you know, they've figured it out. These guys have figured it out big time. And I remember the whole controversy about suits in, I think, Melbourne. That's what it was all about. Is it too dynamic? No, they were fighting over the cardiac output. That's what they were fighting over. I said, if you don't look pretty, we don't care. Can we keep our suits? Now, I'm also going to go into something that we do not pay much attention to. And I'm going to go to two examples, Mark Phelps and Ina Pavic. Now, these are probably some of the most successful athletes. And she always looks like this. She means business. And in real life, she looks like that. Trust me, she means business. And now what they do, and it's very, very important when you sit with these very, very competitive athletes. And what happens is they get into the race day, and they lose. They lose it. Okay, very, very common. They lose it. Okay, so you have to get into a routine. Now, the routines, the psychology of sports medicine is very simple. The concept of it, so when you're training up to get to the, and I'll keep on time, when you're training up to the nationals or whatever you're going for, right, they try to gradually get you there. They don't want you on the 1st of September to be what you call getting to your peak exercise. And the reason why they don't want you to be doing that, if you're not fully trained and you push the limits, you get all these psychological things around exercise, namely the vocal cord dysfunction and so on. When you push the limits, that's when you get all these problems, okay? The fainting, the hyperventilation, a whole lot. So they pace it. They pace so they give you, when they train you for all these, sub goals. And they have sub goals, and it's pretty well written out. Okay, they come in, like yesterday I had a young lady, and I asked her, all right, what are they? What's their goals? And yesterday, Now, race visualization or event visualization is a really big deal. And this is what Phelps does really, really well. Now, you should see Phelps before the race. He's got the headphones on, and what he does is he swims the race in his head. And then, he swims the race, and then he imagines the race, right? And then he imagines the sensations, the shortness of breath, when do I turn my head? All of these things are really, really built into these. Okay, really, really, really built in. Okay, and then run through the race. Okay, now, you have to run through the what-ifs. Okay, now the what-ifs, which we forget about. So you said the what-ifs first is, I get my inhaler, I get on the blocks, okay? And then if I'm getting my vocal cord dysfunction, all right, I'm getting my vocal cord dysfunction. This is how I should breathe. I'm getting a little bit of asthma. I know to breathe a little more slower. This is what I should do. So you go through the what ifs. If I think I got my work, so go through that before the race. Now that's one part of the pre-race preparation. The other thing is anxiety control. But if you do it this way, which the present way of recommending is anxiety control. So you have to build your plan into their pre-race plan. That's what the deal is. So it's a big challenge. So they're really quite competitive, and and you walk in, they're totally informed. Okay, like the young lady yesterday, totally informed. Pat looked at her and said, "Oh my God, you've got to kill the exercise study. You killed the exercise study," and she did. She killed it, and she's only halfway there, and she killed it. Now, I want to at the start of the lecture, he's supposed to give you the objectives. I'm going to give you them at the end because it's the way I seem to learn. He said, what are the takeaways? Asthma and exercise bronchospasm are very frequent, and they can be quite severe, and you would never know. Okay? And I always say the patient's usually not nutty. They're usually right. They're usually right. Sometimes it's hard to prove, and the 50% max exercise test might not get it. Just looking at Eugene's old data, it might not get it. Pre-treat with albuterol. Be careful of your timing. And if I'm saying wear tight suits, I never said that. I'm going to get text messages about this afterwards. High intensity warm up. Now I don't know what's the right amount here. I don't know what the right amount is. And I do this. I really do this. I have to say this is the thing that my patients like the best, actually, from treating the asthma. They walk away and say, and I've given steroids alone, I've given lava alone. This is the one they walk away with. And even yesterday, the young lady yesterday so that's what works. Can we do the test with that on board? And she did. She did great. Now look, vocal cord dysfunction is a big deal. Most patients who are going for nationals or going for significant competitive events, I do actually assume a little bit of vocal cord dysfunction, and I do send them to speech pathology. I say, go and get the 3 lessons, and I tell them work it into their pre-race routine. I do it. I tell them come back after the 3 lessons, and then I talk to them. Yesterday, actually, I taught the 2 skiers. I actually talked to them yesterday and said, did you incorporate this into your pre-race routine? I really got into it. Now, this is what I want to talk about, and then the visualization, and then thank you. And I stole this slide from somebody else.
Thank you, Bernard. Terrific. Let's start with the questions here, and then I have some online as well.
Thank you.
Good.
No, it's... Yeah. We probably should. I think we probably should. The evidence is in their favor. And I think the reason why they never, I think exercise induced, I come think about it, I'd put on 2, but I should go back and look. But we got so used to inhalers with exercise, and I think it's just purely fashion. But the evidence is strong in their favor. Now, and the evidence, honest to God, the evidence is very strong in favor of cromolyn. It's very strong in favor of cromolyn, because if you look, you say a mast cell stabilizer, if cromolyn works that way, I'll just give it a caveat, if cromolyn works that way, it's very much in its favor, and it does not have that vasodilation. It does not have the You see, the problem with as I said, the beta agonists may open up your lungs, but if the blood isn't going anywhere, it doesn't help you very much. So I've gone a bit cromolyn albuterol pre-treatment. I've gone a bit of cromolyn albuterol pre-treatment if I can get it. But yeah. So I think we probably should. Probably should. It's a good question. Good question.
You should provide a microphone.
Thank you. That was a great presentation.
Nice.
I'm curious. The one thing that I always found troubling is all the inflammatory mediators that are released
Yeah.
with exercise, but unlike like a cat challenge or another allergy challenge, we don't see that sort of late phase response clinically. I'm curious to know your thoughts on.
I completely agree with you. And it's very, very well discussed in the literature. And there's no adequate explanation at all, as if there was something else going on. Like, is there something else going on? I completely agree with you on that. And you know what's really, really interesting is this. I couldn't figure this out neither, was that, on those bronchospasm, when you look at the studies looking at leukotriene release, histamine release, there was no real controls. So wouldn't it be nice to take an asthmatic out there? I wondered where there was two problems. Do you get the leukotrienes released, right, in everybody, and maybe they're more sensitive, the ones that get bronchospasm, or is it what's the egg here? And it had never really been done. It's never been. Now, exercise, I got an interesting question here. I got an interesting question texted me here. The exercise has gone out of favor a little bit, and all these studies where what you see it was really rigorously done by McFadden in the 90s, but you don't see very much research other than in these high-end Olympic athletes right now. So I don't know the answer to the question. But it is an interesting paradox. And I just got a text to say that we do recommend tight suits. We do recommend tight suits, and it is always the text says we do recommend tight suits, and it's always well discussed in the committee, what's legal and what's not.
There was a question from Jinar Pak about any measurements of actual airway temperature changes.
Yes.
And your thoughts about the impact of that on airway epithelial cells.
Oh, that's a good question. There's beautiful maps showing that the cold air is going in, and it's in your nose for you and me. And then when we go into cold air, it goes all the way down into bronchi and small airways. And they can show it going all the way out to the airways that matter for us in asthma. They can show it all the way going out. The epithelium, it makes sense that the epithelium is the problem. It does make sense to me that the epithelium is the problem. But I don't remember any data that supports that. I don't remember, it makes sense because that's the first thing that interacts. Yeah.
Particularly in exercise-induced bronchoconstriction in non-asthmatic.
Yes, it does say something about that. But it is an interesting area. It's definitely an interesting area. Yeah. I wish I knew.
Thank you very much.
Thanks, guys.